Hi there and welcome. This video is for all clinicians who want to add self-compassion to their toolbox. I'll be sharing the most common mistakes clinicians make and give you some tips for how to avoid making those. My name is Dr. Christine Breda and I've been integrating self-compassion into psychotherapy since 2008. The first common mistake is to dive straight into doing self-compassion exercises instead of embodying compassion with clients who need to have this corrective relational experience first. So you might be very enthusiastic about sharing your new discoveries with your clients, and you may suddenly see the need for self-compassion all around you. So it's very important not to get carried away by your enthusiasm. How might this be a problem? Most clinicians are unaware that most self-compassion exercises were neither developed for nor tested with individuals with psychiatric disorders. So most clinicians expect that self-compassion exercises reduce the distress in their clients, as is commonly found in studies with the general population. As you will know, self-compassion is a powerful resource that helps us to feel more empowered when we suffer. But as with any powerful medicine, it can also cause side effects or even allergic reactions. And the group most affected by this are individuals with unprocessed attachment trauma, high shame, and low mentalizing capacity. So in other words, most of your clients. So my first tip would be to balance your enthusiasm with wise clinical discernment. To avoid destabilizing a client by accidentally overdosing compassion and thereby triggering old relational pain and all the associated protective mechanisms, you might want to first assess what might be the side effects in this person based on their history, and what might be a safe dosage to start with, and what to do should they have an allergic reaction. Remember that compassion-based work is essentially attachment-based work, and it can easily trigger relational pain. This can show up within the person or within the therapeutic relationship, or within both. It is therefore wise and responsible to first assess experiences of care and of the quality of attachment relationships. This information will help you and your client to find safe access to their care system without unnecessarily re-traumatizing the client. A related pitfall is that clinicians assume that one size fits all, instead of tailoring bespoke interventions that suit the individuals and their needs. Compassion manifests as specific qualities depending on the kind of distress we experience. So if I feel sad because I've lost somebody, then I might need comfort. If, on the other hand, I feel angry and hurt because someone humiliated me, I might need respect and the strength to stand up for myself and to protect myself. How might this become an issue? If you cannot differentiate what the person needs, you may simply be giving them the wrong medicine. For example, if you start to soothe and comfort the person who feels angry for being humiliated, you may be suppressing their healthy impulse for fierce self-compassion and for learning to stand up for themselves and to protect themselves. So you would simply be reinforcing an old pattern of being submissive. So what to do? Apart from tuning into your clients, you might want to avoid overusing the term compassion, and instead use everyday language to find out what it is that they need to determine the specific qualities. Is it comfort, or is it for someone to have their back? Or simply explore together what might be the wisest thing for you to do in this situation to be as well as you can be in the long term. The next pitfall is to use self-compassion exercises in session to meet one's own unconscious emotional needs instead of those of the client. Most clinicians fall in love with self-compassion because it gives us permission to be human, to struggle and to be vulnerable. If we still hold some shame around tending to our own needs in our own time, work may be the only legitimate place to practice self-compassion. The obvious problem is that you may become insensitive to your client's needs. So the easiest solution is to simply tend to your needs outside of work on a regular basis, so you can become the best and most compassionate version of yourself and for your clients. So to summarize, number 1, make sure that you embody compassion in the relationship and that the person has a template to draw upon, Otherwise, self-compassion exercises are likely to fail. Number 2. Make sure to first assess and formulate to develop clear hypotheses about how and why self-compassion might help this client, and to anticipate any potential obstacles. Number 3. Make sure not to overdose compassion either through your presence or through explicit exercises to avoid destabilizing the client. Number 4. Make sure you regularly tend to your own unmet emotional needs outside of your work. This will help you to avoid getting your needs mixed up with those of your clients during your sessions. If you found these tips helpful, and if you would like to learn how to safely activate self-compassion in your clients and get the practical tools for how to do that, then please check out my online course, Self-Compassion in clinicalpractice.com. Thanks for watching.